Welcome back to Plastic Surgery Decoded, the podcast designed to help you better understand plastic surgery. We take the mystery out of it in plain language. You'll find it interesting and useful whether you are already planning a procedure or you're just curious. I'm your host, Dr. Regina Nouhan, and we are now into Season 5 of the podcast. After you listen to this episode, know that you can explore and enjoy many other topics, either through your favorite podcast app or through the website at plasticsurgerydecoded.com. The first 40 episodes, or Seasons 1, 2, and 3, comprise the Plastic Surgery Decoded Classics, with my singular voice covering cosmetic and reconstructive procedures, skincare, and general questions about plastic surgery. The remainder of episodes, Seasons 4 and 5, are interviews with my colleagues around the country to help you learn about the subject. A great variety to choose from. Remember that this podcast reflects my experience and opinion, as well as those of any guest interviewed. It is not intended to provide medical advice, nor is it a substitute for a formal consultation with your physician. So come along with me as we explore this ever-growing world of plastic surgery. Let's go! Our skin is the largest organ in the body. You may have heard that before. It does so much for us that we take for granted, like acting as a protective barrier or allowing us to sense or feel our environment, or functioning to create a first impression when others see us. But even skin can go haywire sometimes and become diseased. Skin cancer is one example, and it's more common than you may think. Now, treatment can be pretty straightforward, but sometimes it's not. Sometimes more specialized repair or reconstruction is required to close up any defect created by the skin cancer removal, especially on the face, where preserving contour and symmetry are so important. Today we have Dr. Joseph Spaniol in conversation to help explain all of the options for repair after skin cancer removal. Aren't you curious about how a nose might be reconstructed if needed? An ear? An eyelid? And how can you work around the negative effects that smoking and other risk factors can have on healing? Dr. Spaniol helps make this clear, and he also has some wise words for detection of skin cancer and prevention. Let's listen in now. Well, I'm pleased today to welcome Dr. Joseph Spaniol. He is a plastic surgeon in private practice with Monarch Plastic Surgery in the Midwest, specifically Kansas City, at my own practice. Welcome, Dr. Spaniol.
Thank you for having me. I'm excited to be here.
Absolutely. And, as we start, could you briefly just tell us about yourself and your practice?
Sure. I'm a Kansas City native, grew up here, did medical school training at KU here in Kansas City, and then did general surgery in Savannah, Georgia, and then plastic and reconstructive surgery fellowship at Temple in Philadelphia.
You've been around.
I've been around. Drug my family
Yeah.
around too. So I'm double board certified in plastic and reconstructive surgery and general surgery. I'm
Wonderful.
a member of the American Society of Plastic Surgeons, the Aesthetic Society, and the American College of Surgeons. Outside of work, I cherish my time with my wife and our 4 children, which keep me pretty busy.
I would imagine.
I also enjoy bike riding, and I've played piano since the age of 6, which I still enjoy doing.
Oh my gosh. Fantastic.
Yeah.
Well, tell us a little bit about your practice. What variety of patients do you see? What types of cases do you tend to do?
Sure. I have a good mix of reconstruction and aesthetic surgery.
Nice.
30 to 40% of my practice is probably skin cancer related, treatment and reconstruction. And then 20% of my practice is probably breast reconstruction. And then the rest is a mix of, cosmetic, the typical things people think of, mommy makeover stuff and facial cosmetics.
Sure.
So I love the balance. I think, the older Kansas farmer with skin cancer who's just happy to have things treated and put back together is a nice balance between some of the more cosmetic patients, which can require a little more hand-holding through things. So I love the diversity of patients that I have in my practice.
Great. Well, what do you love about plastic surgery itself?
I love the breadth of the procedures we offer.
Mm-hmm.
We, as a specialty, are not limited by any organ system.
Yeah.
We're not limited by any type of patient or area of the body. So we operate from head to toe on infants to elderly. And I feel like we're an innovative field. There's always something new to read about, something to explore. And I feel like I could read and learn, forever and never get bored. And that's what drew me to the specialty.
I share those views, yes. All right. Well, we are here to talk about repair and even reconstruction after the surgical removal of skin cancer. But let's first talk about skin cancer itself. What is it?
So, like any cancer, skin cancer is an abnormal growth of cells beyond a realm that is considered within normal limits for that cell type. So, the three main types of skin cancer are squamous cell cancer, basal cell cancer, and melanoma. And each type is treated a little bit differently, melanoma in particular, and they're categorized based on what type of cell they arise from. If you had to pick one to have, basal cells are usually very easy to treat. Their chance of metastasis is incredibly low.
Meaning spread.
Yes, that's right. And they're pretty weak cancer.
And the basal cells are kind of slow growing, aren't they?
Exactly. I think squamous cells are a close second. They can be a little bit more invasive locally, and the recurrence rate's a little higher, but they're still a pretty good one to have if you had to pick. The bad actor of these three is certainly melanoma. It has a higher likelihood of spreading elsewhere in the body at a shorter depth compared to the other two.
What about the appearance of those three types of skin cancer? What would listeners typically see if they had one of these lesions?
Sure. They may start out as just an irregular spot on the skin or a little bit of discoloration or what we may call a sunspot, but often patients may have multiple sunspots, and if there's one that's kind of like an ugly duckling or that doesn't look quite like the others, often the dermatologist will do a biopsy just to make sure. Mm-hmm. And sometimes, that little bit of difference there is enough to show us that it's a skin cancer.
What color would a basal cell and squamous cell be compared to maybe a melanoma?
Basal cell and squamous cell skin cancers are often more pink. They can have kind of an irregularity, kind of roughed up spot of skin. Melanomas, they arise from melanocytes, which make skin pigment. So often it's a pigment change that patients see in the skin. And so that's more of a telltale sign of melanoma. You can have different irregularities as far as coloration, and you can see the edges are irregular. There's the ABCDE of melanoma, which can help people sort of be vigilant when looking for melanoma, which is asymmetry, border irregularity, color change, diameter greater than about the head of a pencil, and then evolution, meaning it's changing from, now compared to a few months previously.
That's a good tool to help people kind of watch for things. Mm-hmm. And, in my practice, most of the melanomas that I saw were pretty darkly pigmented compared to other things on the body, but they don't always have to be darkly pigmented, do they?
Correct. There's a subtype called amelanotic melanoma, which is a melanoma that doesn't create pigment, which can be very tricky to see. It's very rare, but it is out there.
Great information. Well, in general, with skin cancers, are they considered cured once they're removed?
Once they are removed with clear edges, then yes, you're considered cured of that specific skin cancer. However, I always tell patients, I'm sure you did too, that they need constant skin surveillance because their chance of having another one is not low. So at the follow-up, appointment when I'm reviewing pathology with my patients and checking their scar and things, I'm making sure that they have another appointment with whoever's doing their skin check. Usually it's a dermatologist in this area, but in a lot of places it's the primary care doctor.
Oh, right. Yeah.
Yeah. I'll try to tell them, especially if it was a bigger surgery, hey, if you go in regularly, they might be able to catch something that's smaller and you may not need a big procedure like you needed for this last one. So that seems to help them come to terms with that this is going to be a lifelong commitment.
Yeah, it is a commitment, isn't it? You can't just slack off, really. So that's great advice that you give your patients. Well, focusing on the face in particular, how much skin and maybe underlying tissue might have to be removed for a patient to have all of that cancer gone and be safely out of the woods, so to speak, and not really have to worry too much about it coming back, certainly in that spot? And it may differ based on the type of cancer.
Yeah, so for squamous cell and basal cell, you typically need negative margins. So that means that the edge around the skin cancer is clear of any skin cancer cells. And so when we remove it, we send it to pathology and they slice it like a loaf of bread and they look at each section and they see how far from the edge those skin cancer cells are. And so there's guidelines based on the type of skin cancer, how kind of wide we as surgeons need to go to be safe and make sure we have a clear margin. It's that space between cancer cells and where the specimen ends or where you made your incision as the surgeon. And for basal cell and squamous cell, you need a lot less healthy tissue there to be safe. For melanoma, the recommendation is that you need to be significantly wider traditionally to treat the melanoma. And the reason that is melanoma can have a lot of little sort of finger-like projections through the skin and tissues that are not as easily detected by the pathologist. So for that reason, we typically need to go significantly wider with melanoma to make sure we have a safe and clear margin to adequately treat it.
That makes sense. Well, given what you just told us, are you usually able to just stitch up that skin opening that's left behind after you remove the cancer?
Like in a lot of things in surgery and in medicine in general, that depends. So it all depends on, where the skin cancer was, how big is the defect, and what are the goals of the patient, and what can you achieve as their surgeon. So if it's a small spot, maybe on the cheek that, maybe the size of a pea, and you can put it together with a straight line, excellent. As long as that's a scar pattern that the patient's acceptable with, and you don't have any tension, say, on the lower eyelid or on the side of the face or anything.
So it's not pulling and distorting things.
Yeah, exactly. If you have a larger defect or a defect on sort of high dollar real estate area like the eyelid or the nose, then you may need to do other maneuvers to reconstruct it adequately and sort of make that patient whole. The goal is to help them look like they did before, or as close as you can.
Gotcha. Well, I think you've alluded to this, but sometimes can there be a surgical hole, if you will, that is just too big to close up by pulling together and stitching? What do you do in those situations?
Yeah, so if the spot is, too large to close in a straight line, meaning there's just simply not enough skin to pull together, or if in pulling it together you're going to distort the face or the hand or wherever you're working, then you have to think of other options. Mm-hmm. And in plastics and reconstructive surgery, we have the reconstructive ladder. And so you sort of move up in complexity as you move up the ladder. And after the closing in a straight line option, often the next option that we can consider would be something like a skin graft. Mm-hmm. And there's different types of skin grafts. And those are usually a pretty simple procedure. And often they can be done well if they're executed properly. But the downside, particularly on the face, is that if you take a patch of skin from somewhere, say the neck or in front of the ear, it still looks like a patch of skin on the face. Mm. And so a lot of times patients and surgeons will forego that step for that reason. Mm-hmm. But it's still a great option in certain areas. It's really good on the scalp, particularly in someone who doesn't have hair. A little patch of skin on the top of the head, many patients are okay with if they're bald already.
Because you're not going to grow hair through it, right?
Right, yes. But in somewhere that's a little more cosmetically sensitive, like the cheek or the nose, a skin graft might be not the best option if it's going to be a little more noticeable. So then the next step up would be something like what we call a flap, meaning you're moving skin into that area and preserving the blood supply with the skin that's coming in. And you're taking advantage of sort of extra skin in like the zip code over. So if it's, say, the tip of the nose, and if, listeners pinch the tip of the nose, you can feel that skin's not very mobile. So if you've got a chunk of skin missing with exposed cartilage there from a skin cancer, that's not going to be able to close in a straight line. But if you move your fingers up and you pinch the top of your nose where your nasal bones are, or even up higher between your eyebrows, you can feel that there's some loose skin there. And so there's a few different flaps we can use to sort of scoot skin down from the middle or top of the nose down to the tip of the nose to sort of put that part of the nose back together. You're kind of robbing Peter to pay Paul, but often the outcome looks better than, say, a skin graft.
Yeah. So basically with a flap, you are keeping part of that skin still attached to the nearby area, but you're lifting it up and rearranging, sliding or rotating or moving it into the area where you've got this surgical hole and stitching it up. And you're basically saying that where the skin came from is a little more forgiving and you're able to close that up and it can still look pretty decent. Is that right?
Yes.
Yeah, and I'm sure listeners would be relieved to know that there are ways to reconstruct the face and repair the face after skin cancer removal where they can still look as close to their normal appearance as possible, certainly with a scar here and there, but still pretty decent. Well, let's get a little bit more into the weeds with the cancer being in a bad spot, like the nose or eyelids or ears or lips. In those areas typically don't have a lot of extra to be able to pull together. We don't want them to look funny when we finish with the repair. So, how did the early plastic surgeons historically handle these types of situations? What did they do?
Often these wounds were kind of left as wounds. They were allowed to kind of progress, naturally. And, patients were kind of left deformed. They would just sort of heal in. You may have someone with a hole in the center of their nose that never healed with, cartilage that would sort of desiccate and melt away. I believe skin grafts were an option for a while, but you still need a good foundation for a skin graft. And so sometimes those would fail. But something that came along, and I think around the 400 AD or so, and has been slowly evolving, is what's called a pedicled flap, meaning you create a tube of tissue from an area elsewhere on the face or even on the body, and you sort of create this tube of skin, you flip it over and reimplant it onto the patient, let it grow in for a period of time, and then divide or cut where it came from and flip it over again. And in that process, you can sort of march this tube of tissue to wherever you need it to be. And there is a version of that that was brought to light by Harold Gillies in World War I, where he was reconstructing these terrible facial wounds from soldiers using tubed pedicled flaps. And this is a time in our history where the war technology had far surpassed that which medicine could offer. And many of these soldiers were significantly deformed. And Harold Gillies was an ENT surgeon by trade. Plastics was not a specialty yet, but he helped innovate some of these techniques that we still use today. One that I use not infrequently that he really pioneered is the forehead flap, where you're moving skin and tissue down from the forehead to reconstruct usually the nose. And you leave that blood supply intact between the eyebrow and the nose for, I usually do 3 weeks, and then you divide what's in between, and then you can really do a nice reconstruction of the nose. And the patient, yes, is left with a scar on their forehead and some scar around where you put the flap down on the nose, but that's often the best reconstruction you can do for defects that are really big on the nose.
Yeah, so that flap, you can bring a fairly large piece of tissue down to reconstruct the nose. And if we can do the nose kind of in a whole unit rather than piecemeal, then the cosmetic result is a little nicer. But how do you close up the forehead? It seems like you wouldn't be able to get that much skin from the forehead. What do you do?
Correct. So you can close a decent amount of the top of the forehead when you remove that chunk of skin and move it down onto the nose. The bit that you cannot close, you can do a couple things. The one option is to do a small skin graft there, but in my experience, and a lot of papers would suggest that that doesn't look as good as just letting that wound, what we call granulate, and heal in by secondary intent. So it becomes a small wound, like if you were to skin your knee or something and it heals in through a certain process and they end up with a scar there. But that scar is usually less conspicuous than a skin graft would be. For like a female patient who wears their hair in bangs, that's often completely hidden anyway. So again, the answer is it depends for how you deal with the donor site for a forehead flap. But often they turn out a lot better than patients think. I have before and after photos that I'll show them too to try to offer them some comfort.
It is just amazing how mobile some of the facial skin can be, how movable. And I just want to explain for the listeners the reason that you leave a little pedicle is to allow that flap of tissue to grow new blood vessels in the area where we're putting it. And as you say, typically about 3 weeks is good enough time for there to be new little blood vessels so that it's safe to cut through that pedicle and then refine how it sits in its new location. And so pedicle flaps are really kind of amazing. I remember in historical plastic surgery reading about a person who had their nose cut off, unfortunately, and the surgeon took a pedicle flap from their upper arm and stitched it to the nose area, and that person had to have their elbow bent and hand on the head basically for 3 weeks until enough blood supply grew in that it could be divided. And what a horrible existence that 3 weeks would be. However, to have a new nose would be worth it. So, I mean, all sorts of crazy stuff was done.
Yeah.
And we still do a little bit of crazy stuff here and there, don't we?
Yes. Tagliacozzi was the Italian surgeon.
Yes, very good.
And I think that symbol of the patient with their arm like this is the symbol of one of our societies.
But it's iconic is what you're saying.
Yeah, it's iconic. It's an homage to our heritage. I love that.
Yeah. Oh, gosh.
I always wondered how that person would put shirts on and off, but maybe they just had to wear tunics.
I don't think they did. Oh, my gosh. Well, and so you've really told us that some of those techniques in the past we still use now, and we've talked about nose reconstruction. How would you go about, say, reconstructing an eyelid?
An eyelid is, in my opinion, even more complex than the nose. You've got the skin layer, you have the in-between layer where there's cartilage that sits there, and then you've got the complete, inner layer where we have the pink part, the conjunctiva. So when you're reconstructing eyelid, you have to consider each of these three areas. And often you can't just get away with sort of one layer without leaving the patient deformed. So it's common for patients who have a significant eyelid defect to need, higher level, higher expertise care. And there are surgeons that specialize in basically just around the eye area. And they can do certain, like we talked about, flaps between the forehead and the nose. You can do a similar flap between the upper eyelid and the lower eyelid, where they're sort of sewn together for about 3 weeks or so to let the flap grow into its new spot, and then you divide what's in between. Another thing about the eyelid is you've got ducts, you've got tear ducts, you have the lacrimal gland. And so I have had to reconstruct the tear duct a couple times from a patient who had skin cancer. And that's certainly a level of complexity because tear duct is about as thick as a pencil lead.
Tiny.
And it runs from the inside of the eye into the nose. And so it doesn't take a whole lot. The skin cancer doesn't have to be very deep right there to violate the duct. And then you have to put it back together with a little silicone tube, a little stent. And yeah, so definitely a higher level of complexity there when you're talking about eyelid reconstruction. All the more reason to be careful about sunscreen and sun protection.
Good point. What about an ear? If part of the ear has to be removed for skin cancer, and then what about lips?
Sure. Those are both interesting areas to reconstruct as well. Ears, again, you're talking about different layers. You can have the front side of the ear, you've got cartilage in between, and you have the back side of it that's involved. And sometimes you've got a skin cancer that when they remove it, it looks like someone took a little bite out of the side of their ear there.
Yeah.
And so often you may need to make extra incisions on the ear to sort of put it together with the ear tissue you have. Sometimes you can do some skin grafts if you have enough blood supply left, if there is supporting structure in the ear. There's also flaps you can do to reconstruct the ear. You can create that sort of tubed pedicle that we talked about for the forehead. You can have a similar concept with the skin behind the ear. You can flip that up and sew that together, let it heal, and then add the other part in roughly 3-4 weeks later. Ear reconstruction is pretty fun. It's very creative, and that's something I love about our specialty too.
I know. Isn't it wonderful? I mean, you have to be part scientist, part artist to accomplish some of these reconstructions.
Yes, completely agree.
And then what about lips? Is there enough stretchy tissue there to close things up, or do you sometimes have to do something special?
Yeah, just like with eyelids and ears, you're talking about 3 really important layers. You got the skin on the outside and the mucosa, the pink part, and then in between you've got muscle. So that, you can talk and sip through a straw and eat without drooling and things.
Yeah.
And then you have the inside, the mucosa. So you have to consider each of these areas if you have a large lip defect. Often, and listeners can do this, if you pinch your lower lip, there's quite a bit of extra tissue there, thankfully. So as reconstructive surgeons, we can take advantage of that. And you can reconstruct a pretty big lower lip defect by using just the tissue of the lower lip, maybe with some extra incisions.
Just pulling the two sides together.
Yep. And making sure the muscle lines up and the mucosa and the skin all line up. Upper, a little less forgiving, but you can still do some of that. And then if it's just an outer layer defect like skin, then you might be able to do just a skin graft or release skin in both directions with some extra incisions and bring things together. But of course, as you get more complex, you're going to be moving up that reconstructive ladder, and you may need to borrow from the top lip to reconstruct the lower, or borrow from the lower to reconstruct the upper. And so you may end up with another one of those pedicled flaps where the patient's attached between their top and their bottom lip for a period of time while things grow in, and then you divide.
It works, though. It does work.
Yeah. The one that comes to mind is the Abbe flap. That's probably the most common one that we, have to know in our wheelhouse.
Yes. Well, you've touched on this a little bit, but reconstructions of the face in particular, but anywhere, can you do it all in one surgery, or do they sometimes require more than one surgery or stages?
Oh, yeah. Great question.
Could you tell us a little bit about that?
Great question. Often patients think that they can get things done in one surgery. And unfortunately, sometimes we just can't get everything done in one surgery. Like we already talked about with if you're doing pedicled flaps and you're attaching areas that you may have to have some time for things to heal in between. But even still, sometimes you may tell the patient, look, we're going to do as best we can with what we have today, and we'll see how things heal. If you have issues, say it's a lip and you've got like a notch there or some loss of volume, or, you don't like how the pink part of your lip lines up, we may have to come back and sort of touch things up down the line. I think it's common for the lay public to think that that is a failure, either of the surgeon or of themselves or something, but it's often no one's fault. It's just part of the healing process. And again, it's about aligning the patient's goals with what you can achieve as their surgeon. And so I often tell patients, particularly with the nose, if it's lumpy or bumpy or one nostril's pulled up a little bit, yes, we're going to give it some time to heal, and you may need a touch-up procedure down the line, and I'm happy to do that, but let's give it some time and see. Usually things get better with time as things settle, as we say, but it is not uncommon to have to go in and sort of touch things up, make things better, make the scar better, and things like that. And I do try to talk about that with patients, and thank you for bringing that up.
Yeah, just prepare them. Yeah, I always was struck, in my practice, how much time could do for the patient. If you just wait it out, it could be 6 months or a year, and you look at how it looks then compared to how it looked right after surgery. It was just kind of amazing what the body can do for itself, and you just have to give it a chance sometimes.
Completely agree. I'll ask patients sometimes, particularly nasal reconstructions of the nose, at that 6-week appointment with me, they're like, it's still kind of red, it's lumpy, it's bumpy. And I explain healing is a disorganized thing for the first 6 to 8 weeks. The body is throwing down collagen in an unorganized manner. Blood vessels are growing in an unorganized manner. So that's why it's lumpy from the collagen. It's pink from those blood vessels. At that 6 to 8 week mark, the body starts to remodel, reorganizes all of that collagen. It softens, reorganizes blood vessels, and so that pinkness calms down. And then with noses particularly, they still have swelling at 6 weeks. So you want to give them time for things to settle and heal. And I'll ask them, take a selfie like on the first of every month. And then, look at that every month. If you're getting disheartened, say, oh, how did it look last month? And you usually will see an improvement. And I'm happy to continue, I'll continue following them. But usually those little issues that are bothering them settle, thankfully.
Well, we're talking about later down the line, but what happens right after surgery?
Healing it's inflammatory state for the first few days. And the swelling will peak around 2 to 3 days after surgery. I'll kind of compare it to a tough workout or a hike, or a game of tackle football. You're not that sore that day, but the next day or even day 2, day 3 afterwards is that swelling, the bruising kind of catches up to you. So that's usually when things sort of peak as far as the swelling and the bruising. And then things start to calm down as the inflammation from the trauma, which is surgery, as that resolves. I usually see patients back, at that 1 week visit to see how things are healing, get the top layer of sutures out. At that point, a lot of the swelling and bruising has resolved, and it's continuing to resolve. Most of the time, especially on the face, patients can be out and about around 2 weeks with a little bit of residual bruising and swelling, and that can be camouflaged with some makeup. I tell patients that often around the 6 week mark is when they're really going to be about 90% healed. So if they, have a family event coming up, black tie wedding or something, usually at 6 weeks, they have kind of a pink scar, but usually the bruising and swelling is well gone at that point, and they can camouflage with a little makeup. But final result, particularly from nasal reconstruction, is about 1 year. Elsewhere on the face, I would say 3 to 6 months, but that can range based on a lot of factors.
That makes sense. And what about scars after these procedures? And tied in with that, how satisfied do you find patients are after the repair or reconstruction after skin cancer removal?
Yeah, so, every time we do an incision on a patient, we will leave a scar, and I talk to them about that. And there's factors that can make a scar be pretty. There's factors that can make the scar look ugly. There's factors that come into play from them as the patient, from the skin cancer or the procedure they had done, and me as their surgeon putting things back together.
Mm-hmm.
Scars, typically if you can get a repair done with minimal tension and do a good closure, then the scar usually heals really well. It goes through those stages of healings that I mentioned, but usually they soften and they fade with time, and often they're hard to find on a patient's face if you've designed them well as their surgeon. Things we can do to optimize scar are to continue vigilant sun protection, because scars are sensitive to UV damage, and silicone gel is very helpful as well to help keep the scar hydrated.
Mm-hmm. Well, we've talked about good healing. What are some factors that might hinder healing?
There are definitely things that are patient-specific, and there's some surgeon-specific factors, I think, that can hinder healing. The factors that can make healing worse that a patient could bring to the table would be smoking. Smoking affects wound healing terribly. Every time a patient has a cigarette, their oxygen level in their blood drops for about an hour. And so if patients, I talk to them about this, if they're a half a pack a day smoker, that's, I think, 10 cigarettes. So they spend most of their waking hours with the oxygen lower than it should be. And then you add the insult of nicotine on top of that, which causes blood vessels to get tight, so they deliver less blood flow. Between those two hits, smoking can really be detrimental to wound healing.
Yeah, it's amazing.
And so I talk with patients a lot about that there's a high chance that we have, tissue that doesn't heal, or we have, things that develop wounds and things like that if they smoke. Something that I have found helpful in my practice with patients who've smoked for decades, if they can switch to vaping and then taper down to 0% nicotine, I've found that they do heal better. And they're able to sort of go through their habit without going cold turkey during a stressful time in their life that they're dealing with this skin cancer. I've had a handful of patients do that successfully and heal well. Vaping, you still have the problem with nicotine causing blood vessels to get tight, but I don't believe you get the oxygen drop that you do with smoking. And then, of course, if they can taper down their nicotine to 0, then they're basically just breathing in steam.
Yeah.
And so that's something that I recommend to the patients who smoke. And I've seen that it's helpful in my patients.
That's great.
Yeah, thanks. Something else, of course, that's a problem with wound healing is diabetes. Sugar floating around in the bloodstream is inflammatory to healing wounds. It slows the healing process that cells, how cells communicate and how they get into a wound and heal. And then, of course, bacteria love sugar. So if you've got someone who has poor blood sugar control, their risk of having an infection is a lot higher while they're healing. So I really try to discuss with patients to keep their blood sugar under control. Other factors that can hinder healing, I mentioned the patient factors. Of course, there's surgeon factors too. If you're trying to get skin together that's too tight, then that could cause inflammation, which could lead to a less pretty scar. And so that's something we try to avoid when we're doing these reconstructions, is decrease the tension. Absolutely. And then, of course, poor surgical technique. I feel like if you don't line up the skin layers very well, or if, say you beat up the skin edges too much or use too much cautery, you kind of burn the skin edges, you could cause worsening scars and things like that. There's a lot of principles we're taught in plastic surgery to optimize scars.
Right.
That I don't even know we think of consciously as plastic surgeons. They just become part of our day-to-day. But those are a lot of the reasons that patients are referred to us, is because of our fastidious techniques.
Yes. Great way to put it. Well, what happens if the wound doesn't heal well, or it pops open, or if you did rearrange some tissue like a flap and that flap despite your best attempts, just doesn't survive. It doesn't have enough blood supply to it, and the wound breaks down. What do you do in that situation?
If you can catch the wound early, and it's sort of threatened, but it's not completely dead yet, there's some things you can do to try to improve things. You can improve the blood flow to the flap with a certain ointment. If it doesn't seem to be a blood flow issue, or it's more of, it's a wound already, then you can do another kind of burn ointment to help optimize things and heal. But if you do like a flap or something and it dies, then often you're sort of nursing this wound through a healing process. And so if that happens, sometimes you need to clean up the wound a little bit to remove the dead tissue. And we have other wound treatment options as well within our realm. Often if you can get the wound to heal to a point where it's a scar, then you're just dealing with a scar at that point. Sometimes if patients have a bad wound and they're going through dressing changes and stuff, you talk them through that. Yeah, this is a problem, but you're going to end up with a small scar. And if it bothers you, we could do a little scar revision down the line, make that look better. And usually they're okay with that.
So when more time passes, the surrounding skin will relax a little bit more, and then you might be able to cut out that scar and close it up.
Yes.
Well, and the face is so resilient. That's what just amazed me in practice, is that you can do a lot to it and it will bounce back. And so sometimes you just have to be patient, as you say.
Right.
Well, I'm curious if you have any interesting case examples of patients who had to have some type of facial reconstruction or even body areas reconstructed after skin cancer removal. Is there anything interesting that comes to mind that the listeners might enjoy hearing about?
Yes. One gentleman that comes to mind had melanoma right in front of his ear, and it was about the size of a thumbprint. So we talked about earlier how melanoma, you have to be a little more aggressive with taking margins or clear edges around it. And then somewhere that's so cosmetically sensitive as the face, you're talking about a pretty big defect on the side of someone's face.
After you remove it, yeah.
Correct. So for this patient, I coordinated this with an ear, nose, and throat surgeon to check lymph nodes, because this patient's melanoma was deep enough that we had to check the lymph nodes in his neck to stage the melanoma. So melanoma surgery is all about staging, basically. You want to adequately stage the patient so that they can get the appropriate treatment. Because if their lymph nodes are clear, it's a lot different treatment than if they have melanoma in their lymph nodes. So for this patient, the first surgery, which the ENT surgeon performed, he did the wide excision. So he took 2 centimeters around the edge of the melanoma and he checked the lymph nodes in the neck. The patient then had just a dressing on that wound on his face for about a week to 10 days, which is about how much time it took us to check the pathology, because we didn't want to go in and do a reconstruction if, say, the edge was positive, which can happen. It's super rare when you follow the guideline, but we wanted to play this safe with this gentleman. So he did live with a wound on the side of his face for, I believe, about 10 days. Thankfully, the pathology showed that there was no melanoma on the edges. His lymph nodes in his neck were clear, which is great news. And so then I reconstructed him. To reconstruct this side of the cheek, it's such a big area, that you're considering either a skin graft or a flap. And he was a 60s gentleman, very active, didn't really like the idea of a patch of skin on the side of his face. So I did what's called a cervicofacial flap, where you move skin up from the neck onto the side of the face, and you make kind of facelift incisions behind the ear, down the neck, and then towards the front of the neck. You lift all that skin up, scoot it up onto the side of the face, and sew it down. The listeners pinch a bit of their neck. You can feel you've got extra skin in your neck. So like we talked about earlier, you're taking advantage of that loose skin in the neck to reconstruct the side of the face. And what I moved up was neck skin and beard skin.
Yeah.
And so the beard ended up reconstructing his sideburn.
Oh, wow. Yeah.
And so at his post-op appointment, he had a kind of a scar on the side of his face in front of the sideburn. And then the scar went up into his sideburn in front of his ear and down. And you could hardly tell that he had had such a big surgery. And
I bet he was thrilled.
He was really happy. His wife was very happy. And of course, the ENT surgeon and I were both thrilled that he had his melanoma adequately treated. And I don't think he needed any further therapy for his melanoma. But that's one interesting case that I think is worth highlighting.
Absolutely. What a great case. And that's got to be satisfying for you as a surgeon. You took care of this very serious health problem, and in doing so, you left him with a very cosmetically acceptable result and a happy camper. So that's pretty great.
Thank you. Yes. Yes. Very gratifying.
Well, we've been talking about how to repair or reconstruct after skin cancer removal, but we'd be remiss if we didn't mention if or how people might reduce their risk of developing skin cancer in the first place. So, what are your thoughts? Is that possible?
Absolutely. Reducing your risk factors are possible. The multiple factors that increase someone's risk of skin cancer are indoor tanning, sunburns, your skin type. So, paler skinned folks are more likely to develop skin cancer than darker skinned folks. There is some genetic component to it. Having atypical moles, if you've had an organ transplant, if you have red hair, and if you work outdoors. Those are all well-documented risk factors for skin cancer. None of them are that exciting. It's not like try this one simple trick to get rid of your skin cancer risk. Mm-hmm. These are all things that we can work at on a day-to-day basis to, decrease our risk. So obviously the listeners probably all know what I'm going to say. Sunscreen.
Yay.
Yay, sunscreen. What kind of sunscreen, you ask? Typically, in my opinion, zinc-based sunscreens are going to be the ones to go after. Titanium's also good. The ones with a little bit of metal in them tend to hold up better during the day. So you don't usually, you're supposed to reapply them, yes, but I personally don't reapply my daily sunscreen in the afternoon. I don't know about you, but
I do it in the morning and that's it.
Yeah, same. A great option that I tell my friends and family is, wash your face in the morning, do whatever skincare, and then your next layer before you leave the house should be a sunscreen. And there's lots of brands out there that offer a daily sunscreen that really feels like a moisturizer when you put it on.
Yeah.
So for me, after I shave, I do some vitamin C serum, and then I put on my daily sunscreen, SPF 40.
And that's why your skin looks so good now. The listeners can't see it, but you have great skin.
Thanks.
Well, listeners, as they're choosing sunscreens, they're looking at the SPF. So what is the minimum SPF you recommend for people?
For daily use, 30 is the recommended SPF.
Minimum.
Mm-hmm.
Yeah.
It's easy to find something that's 40 as well. If I recall correctly, once you get above 50, you're not getting much of a difference in the UV protection. You're moving from about a 98% UV protection to 98.5 as you go from SPF 50 to SPF 70 or something. That's the concept. Yeah. Other things we can do is sun protective clothing. You walk through any department store now that you can find an area where you've got UPF rated clothing. UPF rated clothing is great when you're out in the sun. Golfing at the beach, by the pool, anything like that. And then avoiding tanning beds.
It's hard for some people.
Yes. And then, if you have any mold at all, you should be seeing a dermatologist and getting at least annual skin checks, because they'll document those things and keep track and do a biopsy quicker than, I would notice differences on my own skin.
Smart idea.
The other things, most people can't change whether or not they're an organ transplant recipient or if they have red hair.
They can't change their genetics.
Right. Or if you work outdoors, many people who work outdoors may not be able to change their occupation a whole lot, but certainly you can modify your risk by being a little more careful with your sun exposure.
Yeah.
Those are the big ones I can think of.
Great advice.
Thanks.
Well, as we're finishing up, I'm just curious if there's anything you'd like to see in the future in terms of advancement for skincare treatment or reconstruction after skin cancer removal. Maybe something that's not even developed yet. What's your wildest imagination? What would you love to see?
I would love to see the area of genomics applied to skin cancer. I think genomics is such a exciting field within medicine where, you may go in for your annual check with your primary care physician and they will have done your genomic analysis and they know what exact risk factors you are for certain cancers, including skin cancer. And then they could have you treated or checked a little more often if you need to. And then beyond that as well, genomics for specific skin cancers, which they are already doing.
How do they check that?
So they'll take, say, it's commonly done for melanoma and other cancers. They check them, and if they're higher risk, they compare that melanoma to a huge database of different melanomas, and they compare the different mutations with, that melanoma to all the melanomas they've studied. And they can look at how all the other patients did who had these, things in common with this melanoma. And then you can sort of tailor the treatment plan to what the patient needs compared to just following sort of general guidelines. I think that's a really exciting area that is widely applicable throughout different medical specialties and certainly to skin cancer as well.
Yeah, so theoretically you could custom tailor the treatment for that particular patient rather than just throw a global treatment at them and see how they do.
Right.
Yeah, that's
Yes.
exciting.
Yes, it is exciting.
Any final take-home points about our topic today or about plastic surgery in general that you'd like to leave the listeners with?
I would say wear sunscreen.
Yay!
Get your annual skin checks. If you have, a skin thing that's growing, they typically don't get better on their own. So I would not ignore something like that. Have it looked at by your primary care physician or your dermatologist so that we can all help keep you well.
Yeah, I think those are wise words. Well, Dr. Joseph Spaniol, thank you so much for sharing your expertise and your time with us today. I think we had a really great conversation, and I think the listeners will come away from this with some really good information. So thank you.
Thank you, Dr. Nouhan. I thoroughly enjoyed our time together. Thanks.
Take care. Well, that's our show for today. Hope you enjoyed it and learned something too. Don't forget to subscribe, rate, and review. Please share this podcast with someone else who might be interested. And while you're at it, check out the podcast website for related topics to explore. It's www.plasticsurgerydecoded.com. And as always, thank you for listening to Plastic Surgery Decoded.